my March Madness slides that you can't see. Alabama versus BYU on the 27th. Let me see what else. Texas Tech versus Arkansas. Michigan State, I'm from Michigan. So Michigan State's still in it. Houston versus Purdue. Oh, and Michigan's still in it too. Yay. Okay, let me see. Women's. Tonight we got Michigan State women's versus North Carolina. Texas is in there versus Illinois. LSU versus Florida. That's always interesting, LSU coach. All right, TLOs and our ELOs, and then we've got a slide that says subsequent prenatal visits. So we talked last week about what we do surrounding that first visit. There's a lot of stuff. So they typically would do counseling via this centering for pregnancy models, or they're all in a room, and they do counseling there, and then they go into an individual room and they ask medical history questions. And then ultimately they get an ultrasound. That ultrasound, you really need to know why they get that ultrasound, what they're looking for. Remember, looking for dating of the pregnancy, which is ultrasound is going to be the most accurate. We're looking for nuchal translucency. We're going to go down to the spine and make sure there's no evidence of neurotube defect as well. And then there's other reasons to do first trimester ultrasound. And the main reasons is vaginal bleeding. And another reason is a person comes in, they're pregnant, they're having abdominal pain. So make sure that it's an intrauterine pregnancy and not an ectopic pregnancy. So make sure you review that slide which talks about first trimester ultrasound. We have one side, and then the other side is a picture of other reasons to do the first trimester ultrasound. So in these subsequent prenatal visits, one of the things you're going to do is they'll have their different different timelines for when they're going to come in, their appointments. So if it's an uncomplicated pregnancy in that first and second trimester, they'll do every 4 weeks for their appointments. And that's until 28 weeks, okay? And then 28 to 30 weeks is going to be every 2 weeks, again, as long as it's uncomplicated. At 36 weeks, they typically will bring them in every single week. We're not going to talk about all the different reasons for them to come in more often than that, so just think about this as an uncomplicated pregnancy. So even if it's a multi-gestation pregnancy, they're going to come in twice as often as they will now. Now down to the bottom there, there's a couple of slides that have this. So we'll kind of just look over that so you understand the timeline on not only the second and third trimester, but the first trimester, and when you should be able to hear fetal heart tones and when different things occur. We're going to talk about all these things, but just so you have a quick reminder of when should I be able to hear fetal heart tones. At about 10 weeks, we should hear fetal heart tones. 18 weeks is about when mom should start feeling the baby. We get an ultrasound done at around 18 to 22 weeks as well. And we check fundal height, and then all the way down to GBS, which is routine strep screening. Okay. Ultrasound for that second and third trimester is the next slide. In that second trimester, we typically perform an ultrasound between 18 to 22 weeks, and that is a fetal anatomy scan. And third trimester, it says 28 weeks, but it's at 36 weeks. 36 weeks for that third trimester. And that's just a routine ultrasound. Make sure there's enough fluid around the baby. Make sure that the cord is in the pin. Checking to see what the fetal live presentation is the baby head down. Because at 36 weeks, mom's only got a couple more weeks before she's going to deliver the baby. There are some other indications for second and third trimester ultrasound, like you can see here in the box. So again, sometimes they're checking for amniotic fluid. If there's any evidence early on that there's decreased or increase in amniotic fluid. They're checking for fetal anomalies, which is primarily done with that second trimester ultrasound. If there's been any evidence that the placenta is low-lying, they're going to continue to do the ultrasounds and check for the placenta placement of the placenta as well. So that second trimester ultrasound, 18 to 22 weeks, is really considered a fetal anatomy scan. They're going to look for fetal anomalies. So look at the head, the brain, the face. abdomen, kidneys, arms, legs, like everything there. They can also identify where the placenta is located, and this is a time period where normally we'll identify the gender of the baby. If mom or dad wants to know, if the parents want to know. Other things we're going to be doing, checking the blood pressure, checking the weight, make sure mom is gaining enough weight and not gaining too much weight. We're going to check those fetal heart tones, fundal height, and fetal movement and presentation are all part of the fetal issue, things that they're going to check. And they're going to go talk to mom about what they can anticipate during the second and third trimester. And as they go towards delivery, where is delivery going to happen and what can they can anticipate in the surrounding delivery. Blood pressure is going to be assessed at every single visit. Normally, blood pressure decreases in pregnancy and then increases. It's kind of a U shape. So it starts normal, it decreases, which is lowest going to be around 26 weeks, and then increase back up to kind of normal. So they ride a little bit low throughout their pregnancy. Okay? So when somebody comes in, their blood pressure is 140 or 90, that's something to be really concerned about. That means that they normally are a little bit low. So if they're 140 over 90, that's the time that we start getting concerned that they might be preeclamptic. These are the tools that we're going to use to assess the fetus in utero. We're going to do a Doppler for ultrasound for the fetal heart tones. We use a tape measure to assess the fundal height, and then hands. Some places will now use ultrasound, but a lot of places still use their hands, and they know what the baby's head feels like versus what the baby's what they call breech, or the buttocks feels like, and they're going to identify the fetal presentation and lie. So fundal height, at 12 weeks, the fundal height is going to be around the top of the pubic symphysis. At 20 weeks, it's going to be at the umbilicus. And then every week after that, we should expect a centimeter growth. So if they're at 21 weeks, we should expect 21 centimeters. So we're going to measure that from the pubic symphysis. Okay, so the tape measure goes on the pubic symphysis, on the pubic bone, and then we're going to measure up to the fundal height. And the fundal height is the top portion of the uterus. You'll feel like a ball, it seems like, on the top portion of the uterus, and that's going to be the fundal height. Okay, so again, measure from the pubic symphysis all the way to the top to the fundus, and 12 weeks, 20 weeks, and every week after that, you should be gaining of 1 centimeter. If we say mom is supposed to be at 22 weeks, but she's measuring at 19 weeks, or measuring at 18 weeks, then an ultrasound needs to be ordered. Or 22 weeks and she's measuring at 25 weeks, an ultrasound needs to be ordered. We got to figure out what's going on. Because at this point in pregnancy, there really shouldn't be any complications. So if we see one of the main things we may notice is that change in the fundal height when we compare it to the estimated date of delivery of conception rates. Pregnant women will typically begin to feel the baby moving around 18 to 22 weeks, depending on if they're their first pregnancy or second or third pregnancy. Sometimes early as 16 weeks, sometimes as late as 20 to 22. So they'll start to feel, it feels like butterflies in their stomach is what it's typically described as. A fetal heart rate, we can start hearing that on Doppler at about 10 weeks. And once you hear it on Doppler once, you should always be able to hear it on Doppler. Okay? So what a lot of times when I did my phase 2 at Fort Campbell, we were responsible for going in and doing the initial prenatal visits, and then we do the ultrasound, the Doppler. And the baby at 10 weeks is super, super small, right? The embryo is really small, the fetus is really small. And so when you evaluate those fetal Dopplers, you're going to start low around the pubic symphysis, and you have to kind of push in a little bit, and you're going to move the probe, all of the Doppler, all over the abdomen. Because a lot of times it takes a good 2 or 3 minutes to be able to find where that fetal heart is. On subsequent visits, what I would typically do is I'd ask mom, okay, where did they hear the fetal heart tones before? And I'd go in that area. Of course, we know baby's going to move all over the place. But what you don't want to do when you don't hear it, you don't want to be like, oops, like I don't hear it. Don't, like, mom is going to wonder why you can't hear the fetal heart tones. And so if you're listen, you can't hear. They're gonna start to get anxious, like, is there something going on? Why can't you hear it? I heard it last time, why can't you hear it? And I would just say, well, I'm actually not very good at this. Let me go find someone that knows how to do this a little better, and they'll be able to give you the fetal heart tones. Because it's a really stressful time early on in pregnancy. So if you can't hear those fetal heart tones, and the parents get all stressed out about it. So just go find somebody. And if not, if they can't hear it, then they'll get an ultrasound, and they'll bring the ultrasound in, and they'll identify it. About 10 weeks is when you're going to be able to hear that. Sometimes as early as 8, sometimes as late as 12. But for our purposes, no, 10 weeks. That's important to know. And the normal fetal heart rate range, 110 to 160. That's what should be identified. If it's lower than that or higher than that, then they're going to get an ultrasound, and they're going to try to identify why the baby's heart would be so low or so high. So once we identify, mom starts identifying those fetal heart rate or the fetal movement at about 18 to 22 weeks, okay, we all are going to have to be asked to start assessing fetal movement. Okay? So fetal movement, really, they typically can't start feeling the baby move until about 28 weeks. Okay, so at about 28 weeks, it's going to be recommended that every now and then they lay down and they start assessing the fetal movement. And that's when they just put their hand on the abdomen and they lay on the left lateral decubitus position, so they're not laying on their back and pressing on their vena cava, and they just put the hand on the abdomen. What we want to do is called fetal kick counts. So fetal kick counts, 10 fetal movements in over 2-hour period of time. And typically the baby's pretty active, so they can feel that even over 1 hour. But we're going to give it a total of 2 hours. We want to make sure mom is hydrated, because the more dehydrated mom gets, that's going to affect the baby, and the baby's not going to be so, and they're not going to have so much movement. So 10 fetal kick counts in up to 2 hours. Okay. If mom does not have 10 fetal kick counts in that 2 hours, the recommendation is for mom to drink something sugary, some sugary beverage. Okay? Because babies do sleep, and about 28 weeks they're starting to sleep a lot more than they did early on. Okay, so babies do sleep, so we're going to drink that sugary beverage in hopes of waking up the baby. And then we're going to start this again. Okay? Once the mom drinks that sugary drink, then lay back on the lateral decubitus, put the hand back on the abdomen, and we're going to look for feel for those fetal kick counts. And really, we should have 10 fetal kick counts in the next hour. So right now, we've been 2 hours. In that 2 hours, we didn't have the appropriate number of fetal kick counts. We drank something sugary. We go back on the lateral decubitus. We have another hour. If in that next hour we don't have those 10 fetal kick counts, a recommendation is for mom to go to this place called the antenatal unit. Okay, the antenatal unit is a place. This actually is a picture of Cedars-Sinai, right? A lot of famous people deliver at Cedars-Sinai. But it's a place typically in the hospital that they drive to, they go up the stairs, and they go to this place. And in this place, it's really designed for pregnancies that have indication or risk of fetal demise. So if we don't have adequate kick counts early on, there's a lot of literature that's out there that says that is an indication of fetal demise. Okay? Or pregnancies at risk of fetal demise. We want to make sure that the baby is moving appropriately. This antenatal unit is also used for patients that are coming in, they have some sort of pregnancy complication, or they perceive a pregnancy complication. Maybe they had some bleeding, maybe they felt like they had a gush of fluid, maybe they're having increased pain or having pain associated with their pregnancy. They go to this place. Prior to 20 weeks, they'll go to a regular ER. After 20 weeks, they're going to go to this antenatal unit. There's a lot of people that come into this antenatal unit. If they're deep high risk, they're going to go into the antenatal unit. Again, if they have evidence of spontaneous rupture of membranes, so they have this gush of fluid, they're going to go in. If they have hypertension, then that's that higher risk portion. Or even people with diabetes, they're going to go into this antenatal unit. If they're walking and they fall, or they're involved in MBC, they'll typically be seen in the ER, and then they'll be taken up to the antenatal unit. And there's a lot of other reasons as well. okay? I wouldn't focus on these tons of other reasons, but I would definitely, kind of look at these reasons and why people come. It's beyond 20 weeks. Okay? So again, other reasons, if there's evidence of fetal demise with decreased movement, if they can't find their fetal heart tone, we use an ultrasound. If there's any evidence on ultrasound of any issues, and they go to the antenatal unit. If they're post-term pregnancy, so beyond 42 weeks, too much fluid, too little fluid, will be monitored in this antenatal unit testing center. Okay? But normally, so if we have appropriate fetal movement, okay, but the pregnancy is deemed high risk, this antenatal testing unit, or the testing itself, will begin around 32 to 34 weeks. Okay? Typically, it's once a week, and certainly be much more often than that, depending on the complication that is being assessed in pregnancy. And sometimes it's going to start even much earlier than that 32 weeks, so more like 26 to 28 weeks, okay? Especially gestational diabetes or hypertension monitoring. Okay, and what they've identified is really what they've identified is if they can identify these high-risk moms, okay, and they bring them in early on and start doing some specific testing, then they improve neonatal survival. Okay, it also assists with maternal comorbidities. It decreases the severity of the maternal comorbidities, decrease risk of fetal death, and what we call iatrogenic prematurity. So they're going to assess the fetus and help reduce the chance of these preterm deliveries, all from this testing. So the testing, there's a lot of testing that is done. We're going to focus on really 2 tests, because I think these are more important that you'll definitely see in phase 2. We're going to focus on the non-stress test and a biophysical profile. So biophysical profile is done if a non-stress test is abnormal. So the non-stress is going to be considered the first line for fetal surveillance, okay? And it can be done with mom kind of sitting up or mom in the lateral decubitus position. But what is it? It's an external fetal monitor. Okay? So they put it on the outside of mom's belly and monitor the fetus, and it also will monitor for any sort of contractions. And it does this continuous fetal heart rate tracing or fetal heart rate monitoring. And it will use the fetal heart rate patterns and accelerations, so increase in heart rate, decelerations, decrease in heart rate, to identify fetal well-being. So what we're looking for is we're looking for accelerations in the fetal heart rate in response to either contractions that might be happening or fetal movement. Anytime the fetus moves, just like us, when we go up and down these stairs, we expect our heart rate to go up and then go down a little bit. So anytime the baby moves, we should expect an increase in their heart rate. If we don't get that increase in the heart rate, that is concerning. We're going to identify that on this non-stress test. So they'll monitor the fetal heart rate for about 20 minutes with these external monitors, and they can monitor for longer, even up to 40 minutes, again, because baby might be sleeping. After 40 minutes, if we don't see a movement in that heart rate, that is concerning. Okay? So again, it's an electronic external fetal monitor, and it's assessing fetal heart rate, which also kind of tells us how the fetal brain is. And it's really kind of the reverse of that. So fetal brain tells us how well the fetal heart rate is. It's a direct correlation. We're looking for that baseline fetal heart rate, 110 to 160, and we're looking for variability in the heart rate. So we want the heart rate to go up and down for over the minutes, right? So we don't want a continuous heart rate of 160, 160, 150, 150. It should, every time the baby moves, you should have a little bit increase and decrease, okay? And for that 20 minutes that they're monitoring, we want 2 episodes of fetal heart rate accelerations. 2 episodes of fetal heart rate accelerations. If mom is less than 32 weeks, we have what's called a 10 by 10, so 10 beats per minute that lasts for 10 seconds. So let's say this, a heart rate is 142, goes to 143, down to 142, 145, but for 10 seconds at least, we need at least 10 beats up. So from 142 to 152, and then it's gotta last for 10 seconds, and then it can come back down to what we call as our baseline, so the average heart rate. If mom is greater than 32 weeks, we want a 15 by 15, so we want an increase in 15 beats for at least 15 seconds. So it can't go 142 to 157, then right back down to 142. We need 142 to 157, and it stays up there. 157, 158, it has to be for at least 15 seconds where we have that increase. And that's all in response to the baby's movement or to contractions. This is because this is an external monitor, and there's no stress on the baby, which is why it's called a non-stress test. Okay, so these are the things we're looking for. We're looking for that heart rate variability. Okay? So heart rate variability, we want 6 to 25 beats per minute. It's called moderate variability, 6 to 25 beats per minute. You gotta know that. Okay? We don't want minimal, which means there's less than 5 beats per minute change. And then we don't want it too much, greater than 25 beats per minute change is going to be called marked variability. There's something going on, something's agitating baby. And baby is having too much of a deep change in their heart rate. So moderate variability is what we're looking for, 6 to 25. So on the top here, we can see this first line here. So let's kind of orient you guys to what these lines mean. So let me see that. Let's go to this middle one. It says non-stress test. From dark to dark is 1 minute. From dark here to dark here is 1 minute. Here to here, 1 minute, here to here. These lines in between, 10 seconds. Okay, lines in between are 10 seconds, dark to dark is 1 minute. So if you look at this top one, we can see we pretty much have a flat line. We go up a little bit, down a little bit, up a little bit, down a little bit. But there's really not good variability in that heart rate. Okay? Per minute, okay, from dark line to dark line, we want to see 6 to 25 beats per minute change. We're not seeing that there. If we look at this next one, okay, what do you guys think about that? Is that a lot of movement? That's too variable. That's too much. Something is agitating the baby. That is marked variability, and that's not good. That's an indication of something is agitating the baby and increased chance for fetal demise. This bottom panel here, so we've got this top panel, these are contractions. So we've got contractions that are occurring, but the baby is heart rate is changing even without contractions. So normally, associated with contractions, we're going to have a change in the heart rate. But here, the baby's heart rate is constantly changing up and down. This middle one here, this is what we call a moderate variability. So from minute to minute, we can see. So what you want to do is you look at, first of all, the baseline. And the baseline is just kind of average heart rate that's going through this entire strip. And the average baseline here, if we look at it, it's probably around 120, 130, what did that say? 150. So it's about 150 or so if we kind of average all this out, about 150. So what we want to do from minute to minute, and then we want to look and see, so we have 150, and then we go all the way up here, and we come back down to 150, but we're having these changes in the heart rate for that entire minute. When we're up here, we go up here. Now, if you look right here, from here to here, is that more than 10 seconds? Do you guys see what I'm at? So we've got 10 seconds, 20 seconds. Do we have an increase of at least 10 beats per minute? Yeah, so that would be an acceleration. That would be an appropriate acceleration. So that's what you're going to see on the test. You're going to see something like this, and you're going to need to be able to identify the acceleration. It'll be obvious. Okay? It'll be obvious on the exam. Okay, but we're looking for the variability. We're looking for those accelerations. Okay, and we're looking for the fetal heart rate. So those are the 3 things we're looking for. We want to make sure the heart rate 110 to 160. We want to have that 6 to 25 beat per minute variability, and we want to see accelerations that are either 10 by 10 or 15 by 15. Okay, so 2 accelerations over that 20 minutes. If they need to monitor a little bit longer, they would go up to 40 minutes, okay? Given consideration that the baby may be sleeping. But what we want is 2 accelerations over 20 minutes. In less than 32 weeks, we're gonna do that 10 by 10. Greater than 32 weeks, we're gonna do that 15 by 15. So we're gonna look for that, where it comes up by at least 15, last 15 seconds, and then comes back down to our baseline. A non-reactive strip, it might indicate that baby is sleeping, so we're going to extend that out to 40 minutes. Okay? It might indicate there's something going on with mom. Maybe mom took some sort of sleeping aids or is on some sort of substance that is decreasing mom's metabolism, and that's going to be affecting the baby. It might indicate fetal cardiac or fetal neurologic abnormalities, because heart is brain. It might indicate fetal acidemia or fetal hypoxemia. So non-reactive, we say non-reactive means that we don't have those accelerations. We don't have that variability going on. Okay. So again, here's a couple of examples. So here on this top one, so this is a mom that comes in, she's got severe DKA. Okay? She's severely acidotic. Okay? So this top one, do you guys think that's a good strip? Just kind of comes up and down, but we don't see any variability, right? We don't see any variability of that heart rate from minute to minute. So you see a little bit here, it comes up a tiny bit, okay? But not even up by not even up by 10, okay? And then it's just really kind of smooth. This is mom, severely acidotic, that is affecting baby's heart rate, okay? Here's the contraction. Mom's barely even contraction. It comes up a little bit of contraction here, a little bit here, and the baby really doesn't respond. Once they treat mom's acidemia, what do you guys think about this? You think that's a little bit better? Now we see the variability in that heart rate. Okay, we see from almost beat to beat variability. Definitely minute to minute we have variability, up and down, up and down. And then we can see a little acceleration here, and it comes all the way over here. Okay, we've got an acceleration here as well. So once mom was fixed, then we see that response in the baby. The change in the heart rate, change in the variability, and change in the acceleration pattern as well. Okay, so here's another indication of a reactive strip, So this is down at the bottom, this is mom, and mom is contracting. Okay, at the top, this is baby's response to that. So baby comes up, we've got acceleration here and acceleration here, and then we have all this variability, which is good. It's not too much, but it's good because it's coming up and down. We've got another acceleration here in response to maternal contraction. So it could be response to baby moving, or it could be in response to maternal contractions. And then at the end here, we've got another acceleration. So this is considered a reactive strep, reactive non-stress test. 2 accelerations in 20 minutes, 10 by 10 or 15 by 15. This is considered a non-reactive. Okay, non-reactive. We have our fetal heart rate here at the top. We've got a contraction at the bottom. Mom is not even contracting all that well. So, in response to mom not contracting well, we don't have a lot of acceleration. Does anybody see any significant acceleration here? We've got something here, but it doesn't even really go up by 10. It lasts quite a bit, but we're not up for that full 10 beats per minute. And we don't have enough here. We have a little bit here, but we don't have that 2 iterations of accelerations that are lasting at least 10 by 10, 15 by 15. And we don't have a lot of variability in the heart rate either. So this would be considered a non-reactive. Yes, ma'am? So not necessarily. Even Braxton Hicks, you can see a little bit, but the difference is when we'll talk about this, but Braxton Hicks, you're going to have changes on the monitor, but we don't have any cervical changes that are associated with it. So we'll still see something on the monitor. So this doesn't necessarily mean that. This probably means more that mom is in a poor state of health. So if that non-stress test is, that non-stress test is non-reactive, okay, and this is typically considered now a high-risk pregnancy, or if mom has a high-risk pregnancy, they will do that non-stress test. If it's non-reactive, the next thing they'll do is this biophysical profile. So remember, the first sign or the first line for fetal surveillance is going to be that non-stress test. That's abnormal, that's non-reactive, we'll do this biophysical profile. So biophysical profile is done, if we have decreased net fetal movements, we're going to have decrease in those accelerations, we're not going to see those. Okay, again, typically done about 32 weeks after that non-stress test, but certainly can be done earlier, just like the non-stress test can be done earlier. This takes quite a bit more time, up to about an hour to do this full biophysical profile. And it's assessing 5 different fetal measurements using that non-stress test and using an ultrasound to assess amniotic fluid. And so there are 5 different fetal variables, the movements that they're assessing. They're going to do that non-stress test, looking for the fetal heart rate acceleration. Normal would be reactive. If it was reactive, we wouldn't have to do the biophysical profile. So this is a non-reactive. Okay, they're going to use an ultrasound to look for fetal breathing movements. Okay, they're going to look for fetal movement on the ultrasound. They're going to look for fetal tone. Is baby kicking out and hitting her arms out and back in, or are the arms and the legs just kind of flopping around? Because normally when baby's in the belly and they're moving, things are coming out. Okay, they're punching, right? They're kicking, and moms that have been pregnant know that. So that's what we expect. So look for fetal tone. And they're going to look for amniotic fluid index with the ultrasound as well. So it's really important that you study this slide. You're going to be asked a couple of questions on this slide. So make sure you understand what you're looking for. So fetal breathing movements, more than 1 episode. Okay, fetal movements, more than 3 discrete body movements. Okay, that fetal tone, and then amniotic fluid. So the amniotic fluid, what they're looking for is typically they'll take the single deepest pocket and they'll measure that. And one's greater than 2 centimeters. So greater than 2 centimeters for that single deepest pocket, and they'll assess that with the ultrasound. If when they assess those 5 different movements, each of those 5 movements is going to be assigned 2 points. Okay, so we're looking for a score of 8 to 10. 8 to 10 with a normal fetal pH, that is reassuring. Okay, that is a good sign. If they have a score of 6, okay, the recommendation is to monitor, retest and monitor. Okay, or if they're greater than 36 weeks, they may talk to mom about delivering the baby. If the score is less than 4, that is non-reassuring. They need additional evaluation. Or if mom is greater than 36 weeks, they may talk to mom about delivery. I would be more focused on the 8 to 10. Okay, more focused on the 8 to 10 arena, and know that that's just normal. Because if it's abnormal, you guys will probably not be associated with doing any additional evaluation. Okay, other things that we're going to do in this 2nd and 3rd trimester. So we talked about urinalysis and urine culture at the very beginning. Okay, we talked about repeating urine culture. Those are not necessary, but they will repeat a urinalysis every time they're seen to look for other things. Look for glucose, look for protein, especially in the setting of hypertension. Look for nitrites, okay, which might indicate infection. And look for ketones, which might indicate dehydration. Or if mom is diabetic, might indicate a problem with diabetes. Okay, genetic testing, additional genetic testing may be done. We do some in the 1st trimester, and some can be done in the 2nd trimester as well. Diabetes screening is done in the 2nd and 3rd trimester. We'll do CBC, HIV, syphilis, chlamydia, gonorrhea for high-risk patients. Otherwise, they just do the initial screening, initial testing in that 1st trimester. And then at 36 to 37 weeks, we'll do group B-strep testing. Okay, so second trimester genetic screening. If you remember, in the first trimester, we're going to use that ultrasound. The ultrasound is going to look at that nucleotranslucency that may indicate Down syndrome, because it's only a screening test. Remember, if they have the nasal bone, they kind of cross each other out. It's less likely they have Down syndrome if they have nasal bone. And then they're going to look at the spine as well. Okay, that's on that first trimester. In the second trimester, they're still looking for Down, because the Down syndrome is the number one aneuploidy that women are going to have to deal with. Okay? They're going to look for trisomy 21, trisomy 13, and trisomy 18. So 21 is the Down syndrome that most of us have seen even on TV. 13 and 18 are a lot more severe forms of Down syndrome. The testing that they do in the second and third trimester, they're going to do the blood test, and it's a triple screen. If that triple screen is abnormal, then they will do a quad screen. The triple screen has maternal serum alpha-fetoprotein, and remember that identifies neural tube defects. They're going to do an HCG and estriol as well. In the quad screen, they do those same 3 tests, but now they're adding in inhibin A. So inhibin A is produced by the placenta. So if it is increased, that's an indication, again, or a concern that this patient may have Down syndrome. If the screening is abnormal, okay, the ultrasound, the triple screen, the quad screen, or for women that have an increased risk, baseline increased risk of aneuploidy, so those over the age of 35, or if they're pregnant with gestational pregnancy with twins or triplets at 32, they've had that abnormal ultrasound, if they had previous child affected with Down syndrome, or they're known to have just genetic disorder, those patients are going to be offered diagnostic testing. And diagnostic testing comes in 2 forms. The earliest form is going to be chorionic villi sample, or CVS. Oh my God, CVS. You guys go to CVS? How long are those receipts that they give you from CVS, right? It's like my kids' Christmas list, right? Like this long. I asked them the other day, I was like, what? You guys could save so much money by not printing off the years. This is ridiculous. But CVS can be done to 10 to 13 weeks. The earliest diagnostic test, 10 to 13 weeks, okay? And it's CVS. And in CVS, they're going to go trans-cervical, and they'll take a piece of the ultrasound guided trans-cervical, and they'll take a piece of the placental tissue, and they'll send that off for testing. Because it is done earlier on, there is an increased risk of pregnancy loss of 0.22%. So not significant, but still, they talk to the parents about that increased risk of pregnancy. Another diagnostic test is amniocentesis, not screening, but diagnostic. Amniocentesis is done between 15 and 20 weeks. And they take ultrasound guided, take amniotic fluid, they send that off for testing. Very accurate, okay? But does have some risk of waiting with mom, risk of rupture of membranes because they're going through into the amniotic sac. Okay, fetal loss 0.2%, and then fetal limb abnormalities or infection can occur as well. So they are not without risk, but there are diagnostic tools for assessing for fetal aneuploidy and fetal abnormalities. So this is amniocentesis, 15 to 20 weeks, ultrasound guided. They'll go right into the amniotic sac, and we'll take the fluid out of there. And then this is the CVS, this trans-cervical chorionic villi sampling. Come in through the cervix, and they'll come up by the placenta, ultrasound guided, and they'll take a piece of that placenta tissue and they'll send that off for evaluation. So that's what we're doing, our second and third trimester genetic screening and diagnostic testing. Okay? Between 24 and 28 weeks is a time to do our gestational diabetes screening. Okay, this is can be done in 2 steps. Depends if step 1 is abnormal. Step 1 is normal, then we're done. If step 1 is abnormal, then we'll go to step 2. So step 1, they have mom come in, they drink this, it does not have to be fasting, okay, it does not have to be fasting, they come in overnight, or come in the next morning, it's called a glucose challenge test. Mom comes in the morning, she drinks this 50 grams of this sugary beverage. Anybody had it before? Tastes pretty terrible, from what I understand. It's pretty terrible. Looks really good though, it tastes pretty bad. But they drink this glucose, and then an hour later, they get their blood drawn. And they're gonna assess what their blood level is after giving them a bunch of glucose. And if it's greater or equal to 140, then that is considered positive or considered abnormal. Okay? If it's abnormal, then now they have to go on to step 2. Okay? So again, step 1, glucose challenge test. They do not have to be fasting. They usually will come in the morning because they usually come in the morning because they have to just kind of have time slots for these patients to come in. They do the 50. If the 50 is abnormal, greater than or equal to 140, they go on to step 2. Okay, step 2, this is a fasting glucose. Fasting glucose. So mom comes in the morning, she drinks this 100 grams, so they get 2 of those. And then they will test their blood at 1 hour, test their blood level at 2 hours, and plus their blood level at 3 hours. So it's a whole morning process. And there's these different thresholds that mom must meet. So we have fasting at 95, and at 1 hour, we're looking for something less than 180. 2 hours, less than 155, and 3 hours, less than 140. If that's abnormal, they're considered to have gestational diabetes. So, if I was you, I wouldn't focus so much on the table. I wouldn't memorize that, but I would definitely memorize what would cause mom to have to go into step 2. Okay? And when is this done? 24 to 28 weeks, greater than or equal to 140. And it's a glucose challenge test. Glucose challenge test is the name of it. Okay, another thing that is done around 28 weeks is Leopold's maneuver. Leopold maneuver, this is assessing fetal presentation and live. Fetal presentation and live. They know that baby is still going to move, but starting at 28 weeks, they're going to use their hands, and they're going to identify where is the breech, or where is the buttocks, and where is the head of baby. Where is baby laying? Is it vertical? Is it horizontal? Are they transverse? So that way, and they're going to continue to do this every single visit that mom comes back, so they can identify early on if there's any indication that this is going to be a breech delivery. They're going to try to avoid that. So if they identify that baby is not head down, okay, they're going to continue to monitor that. And then closer to delivery, they can try to move baby around with some different maneuvers. So this is called Leopold's, and this is for presentation and live. Let's see if baby is engaging or not. 28 weeks, they still got lots of room to move, but that's how they do it. And the first couple of times that you do that, you won't have any idea what you're feeling. You won't know if it's the elbow, if it's the knee, if it's the foot. But after a couple of times of doing it, you can really actually feel. It's like when you did your ultrasound. The first couple of times you looked at that ultrasound machine, and now on the screen, you had no idea, it's all black and white, right? It's the same way here. After doing it a couple of times, you can really determine if this is the head or if this is the buttocks. And nowadays, some people will just do the ultrasound, but a lot of times they'll do that. Another thing that's important around 28 weeks is trying to identify if there's going to be a problem with RH incompatibility. So one of the very first blood tests that are done, or part of that first set of panel of blood tests, is going to be the mom's blood type, ABO-RH. Okay, so RH factor, that's a protein that is found on some red blood cells. If it's RH positive, they carry the protein. If it's RH negative, then they don't carry the protein. It's important to identify if mom is a RH negative status. If mom and dad had different blood types, that's called RH incompatibility. Okay? And if the Rh incompatibility is a 50% chance, if mom is Rh negative, dad is Rh positive, 50% chance that baby will be Rh positive. And that means mom will create a reaction towards baby in that Rh positive blood. Okay? This is really isn't much of a problem in the first pregnancy because mom hasn't created antibodies yet towards that Rh positive. But in subsequent pregnancies, this becomes a problem. Mom's Rh negative antigens are going to attack the Rh positive baby's blood. Okay? And what it does is cause hemolytic anemia. So it causes lysis of baby's red blood cells. Okay? So in order to prevent this, mom might be given or will be given Rogam. Okay, so this is just what I said. We have this Rh negative mom, Rh positive fetus, and not the first pregnancy, but subsequent pregnancies. And the reason why it's subsequent pregnancies is at delivery, oftentimes we have maternal and fetal blood mixing. That's when the antibodies develop, when we have maternal and fetal blood mixing. Okay? So if during the first pregnancy there's blood mixing somehow, it can happen. But this usually we see in subsequent pregnancies. So then mom is going to attack the baby. Mom's going to develop these antibodies in that first pregnancy during delivery. So what Rogam does is Rogam binds to and inactivates those Rh positive fetal proteins, the fetal Rh positive proteins, before mom's body recognizes those as foreign and then creates antibodies. So it prevents a maternal immune response, essentially. Mom's body's not going to attack those fetal red blood cells. Okay. So we're going to administer Rogam in unsensitized moms. So the mom is Rh negative, and this is a second pregnancy or more, we're going to administer Rogam anytime we have evidence of fetal maternal blood mixing. Mom is in a car accident, mom has a fall, there's increased risk of maternal fetal blood mixing. If this is an ectopic pregnancy, okay, and at any point, they're going to administer Rogam. Or if mom is undergoing something like amniocentesis or chorionic villi sampling, there's a high risk for maternal fetal blood mixing, she's going to get Rogam. Okay. If mom is greater than 12 weeks and she comes in with vaginal bleeding or has a miscarriage, she's going to get Rogam. Let's take a break so I can explain something. Let's take a break. For blood, if mom needs a blood transfusion, oh, I see what you're saying. So yes, so well, you shouldn't be doing that. But if let's say like you're in a car accident and they come in, you've got to do emergency release blood, they will give them Rogam because that's usually a O positive, right? So they're going to give them Rogam, yes. So at BMC, it doesn't matter if you're Rh positive or Rh negative, they give you Rogam. It doesn't matter after 72 hours if mom is, if partner is positive, baby, it doesn't matter, they give it. So I don't know why they do that, but that is what they do here. And I only found out from people here that have been pregnant, like, oh no, I got it anyway, and I'm Rh negative, and my husband's Rh positive, my husband's Rh positive, but they still give it. But that's not the norm, that's not the guidelines. But when you go to phase 2, you may see something like that in the military setting where they're giving it to everybody. And when you go to phase 2 and you take the phase 2 exam, okay, for OBGYN, women's health, remember these guidelines, because sometimes what we see in phase 2 is not actually what's in the guidelines. People have their own personal way of doing things. So understand these are the guidelines. 28 weeks if you're Rh negative, and then 72 hours, within 72 hours, if Rh positive baby or unknown dad or Rh positive dad. Okay? And the standard dose is 300 micrograms, one shot. It's good for 13 weeks, which is kind of important to know, because if you had to give it early on from that topic, and then they come in, later on, and they have a complication, then they, know it's good for 13 weeks, right? Bleeding early on, and then later on as well. Okay, so let's sort of check on learning here. Antenatal testing, 33 weeks, which of the following is most reassuring? Okay, NST with absent variability, late decels, no, we don't want any deceleration, no fetal heart rate. So score of 2 and biophysical profile, no. So C, yes. 2 accelerations, 20 minutes, 15 by 15, because she's 33 weeks. Less than 32, 10 by 10. Okay. HIV screening done at all new OB appointments, and then a repeat will be done in the third trimester for high risk, right? And repeat, or do repeat testing for high risk. So high risk. So when someone has HIV, think about it, they probably have an increased risk for other infections. And so babies that are born with congenital HIV really have only an average survival rate of about 3 years. Oftentimes their disease will progress to AIDS by age 1. And that's even in literature from last year. And so we want to try to prevent that, and that's why they do this additional screening. They also have increased risk of other infections like urinary tract infection, other STDs. That increases the risk of postpartum or peripartum infections. Certainly increased mortality, especially if they're not on antiretroviral therapy. Okay. Increased vertical transmission rate, okay, which mom to baby, 20 to 30% can occur around the time of delivery, so intrapartum or even postpartum, expressly if mom breastfeeds, it increases the risk. So treatment, these guys can take standard antiretroviral therapy. You encourage them to take antiretroviral therapy. And that decreases the risk of vertical transmission to very low, 1 to 2%. If their viral load is less than 1,000, they can actually do vaginal delivery. If their viral load is greater than 1,000, C-section is recommended. Okay? No breastfeeding. Okay? That breastfeeding increased risk of transmission. Even if they're on antiretroviral therapy, there's still an increased risk of up to 20% transferring that to baby in the postpartum period. So less than 1,000 vaginal delivery, okay, greater than 1,000 C-section delivery, and then no breastfeeding. Of course, in other underdeveloped countries, even if they have HIV, they will breastfeed a lot of times because the water is not conducive for formula feeding. And so they run the risk and have a much higher risk of HIV in those underdeveloped countries, partly because of that. Gonorrhea and chlamydia, we're going to check that in that first trimester screening, and then a repeat screening in that third trimester for the high risk. Okay, people that have gonorrhea, chlamydia, they have increased risk of complications in pregnancy, increase your preterm labor, chorioamnionitis, which is an intrapartum infection of the chorion, and then postpartum endometritis as well. Of risk of delivery for chlamydia, neonatal conjunctivitis can occur if mom has an active chlamydia infection and delivers through that. Neonatal pneumonia can also occur. And for gonorrhea, you can also get conjunctivitis. So babies that come in that you may see for their 1 to 2 week well baby check, they come in with ocular discharge, or if you're doing your ER rotation, you may see this. That is very concerning for chlamydia or gonorrhea. You have to do a swab of that and send that out. Remember, gonorrhea and chlamydia often go together. So typically, if you have one, we'll treat for both. Number one cause of neonatal sepsis in the United States is group B strep. Group B strep. Okay? So I would probably know that that's number one cause. It's also a cause for a lot of respiratory distress syndrome, pneumonia, meningitis, and fetal neonatal death Okay, 1 in 4 women are carriers of group B strep. Okay, and they carry that in their perineum or their rectal area. So because of that, we're going to test for this automatically for the majority of patients between 6 and 37 weeks. Okay. If they've had bacteria in their current pregnancy, so in other words, when they did their urine and that urine showed group B strep, they don't necessarily have to test. They'll go ahead and treat for group B strep at the time of delivery. As mom goes into having contractions, goes into delivery. Or if they gave birth to a baby that had invasive group B strep, so things like meningitis, sepsis, all from group B strep. There are times we're just going to treat these patients. Okay? We're going to give antibiotic prophylaxis. And again, we call this intrapartum. And at the time that mom goes in for delivery, starts having contractions, she's going in for delivery, they're going to give intrapartum antibiotics. Again, previous infant with group B, invasive group B strep, a very sick baby. Group B strep bacteriuria in this pregnancy. If they're positive group B strep screening, okay, unless a C-section is planned. So even if a C-section is planned, oftentimes they will still check for group B strep in case mom goes into labor before the planned C-section. Okay? Or if they have an unknown group B strep result and they're less than 37 weeks, they're going to go ahead and give antibiotics. If they have amniotic fluid rupture, amniotic sac rupture, greater than 18 hours, 18 hours, they're going to go ahead and give intrapartum antibiotics. If during the delivery process, mom has a fever, greater than 100.4, they're going to give antibiotics automatically. If a group B strep status is unknown, but previous pregnancy with a positive culture, then they will give antibiotics as well. Okay, so when do we not give antibiotics? Again, if a C-section is planned, again, most times they'll still test, maybe just in case mom goes into labor, or if they have negative screening. So you got to know when we're going to give it and when we're not going to give them. Okay. Other things that we're going to discuss the second and third trimester. Make sure that mom, if she wants childbirth classes, make sure that those are offered. Where is mom going to deliver and how does she get there? Okay. Where is there a pediatrician that is set up? Okay. How does mom know that she's going into labor? What are the signs and symptoms? How is mom going to feed baby? Okay. How is mom going to take baby home? What for the car seat? Does mom want an epidural? Do they want pain management during delivery or during the intrapartum period? And then postpartum depression, we talked about, as well as postpartum contraception. So the birth plan has to be discussed. Whether mom wishes during labor and then during delivery, and mom will talk about that with the entire birthing team. Okay, will mom have an epidural or not? What happens if complications arise during the delivery? We'll talk about these possible complications and then the solutions to those complications. And again, at 20 weeks and beyond, we talk to our patients about where should they go if they have an issue with pregnancy. So some patients, so here at BMC it's 22 weeks, but most of the places it's greater than 20 weeks. They'll go to the labor delivery, the antenatal testing unit is where they'll go. And then at 20 weeks, these patients are kind of in that peri-viable area. So we want to make sure that if they're having things like contraction or loss of fluid, any sort of vaginal bleeding or vaginal discharge, that they go to that antenatal unit of labor and delivery for evacuation. The literature talks about breastfeeding and says that breastfeeding is certainly the best way of feeding our babies, but really just feeding a baby is the best way of feeding babies. Okay, so we do know that breastfeeding promotes bonding between mom and baby, but anytime that we can feed baby, whether it be breastfeeding or bottle feeding, it doesn't really matter, as long as we have a plan on feeding baby. Okay? I told you the story about my son when they dropped him off, they gave me 20 little bottles of formula, and I was like, this will last me forever. And like within a day and a half, it was gone. And I'm like, well, now what do I do? How do I feed this baby that's crying all the time? So contraindications though to breastfeeding, HIV, even in the United States, if they have chemical dependence, medications that they may be on, like lithium, is contraindicated. If they have active TB, contraindicated as well. Otherwise, we will encourage breastfeeding, and they'll have do breastfeeding classes and breastfeeding before she leaves the hospital as well. Full term, remember, is between 37 and 41 and 6/7 weeks, so just below 42 weeks. So we want to talk about any complications that may portend for this mom, the baby wants to hang out with mom a little bit longer. Okay, uncomplicated pregnancies will typically await spontaneous labor until about 41 and 6/7 weeks or so. Okay, unless fetal or maternal complications force them to induce delivery or push mom into a C-section. If mom has had a prior C-section, we'll talk to the mom about having another C-section, or they can have a trial of labor after C-section. If mom wants to have a vaginal delivery, you can certainly have that nowadays after a C-section, but they'll talk to them about the potential complications associated with that. Otherwise, repeat C-section is typically scheduled for 39 weeks gestation. We got to talk about when labor should begin, is the timing of labor. Again, how are they going to get baby home? Where's the car seat? How is the car seat going to be faced? How do they put the car seat in the car? Okay, what clothing are they going to have? Do they have a crib that is set up and that meets the safety requirements? How is baby going to be put to sleep? Remember, to help reduce the chance of SIDS, we call this back to sleep. Baby should be laid on their back, and they'll talk to mom, the parents, about that as well. When is baby going to be circumcised? Typically, circumcision occurs before baby goes home. If that's not the case, do they want circumcision? And if not, if they do, then when is that going to be done? Baby needs hepatitis B immunization. That's going to be done within the first 96 hours. And then a single shot of vitamin K is done, and that helps reduce bleeding in baby. They'll do conjunctival eye care with erythromycin. Even if mom delivered a fully healthy baby, not through gonorrhea or chlamydia, they're still going to do conjunctival eye care as well. Anybody know what we used in the pre-antibiotic area for conjunctival eye care? What would you guys say? Yes, how do you know that? He told you? Oh, damn it, stole my thunder. Like, that's so crazy though. It's like, yeah, late 1800 things. That's so crazy. Immunizations, so in mom, we already talked about a lot of the immunizations. Of course, they didn't get it before a pregnancy. There's some that they get during pregnancy. Influenza they can get hepatitis B. We want to avoid live viruses like varicella, MMR, contraindicated. HPV is not recommended during pregnancy, but it can be done during breastfeeding. That's fine. Tdap is going to be done at that 27 to 36 weeks. And then COVID-19 vaccine can also be given. Hepatitis A, hepatitis B can be given if mom was exposed. And then I lost it. I was going to say something else. So here's a couple of charts that just talk about when vaccines can be given. MMR is red. We've got green for influenza, and then we've got green here for tetanus as well. Okay, so just really kind of focus on not getting the live ones, so red ones, and then the green. What we can give and what we actually can't give. That's what I would focus on. Okay, so when pregnancy, we want to think about for our routine visits, our first trimester precautions, bleeding, if you have any abdominal pain, if you have UTI signs and symptoms, those are concerning in our first trimester. Second and third trimester, bleeding is still concerning, abdominal pain is still concerning. We want to have the appropriate fetal movements, okay? So, you know, that 18 to 22 weeks, around that time frame is when moms should start feeling the baby. It's important for us to tell parents that. Contractions, what do contractions feel like? When can they expect contractions? Okay, headaches, they're starting to get new onset headaches, that is concerning. And a lot of people don't have blood pressure cuffs at home, so we tell them if they have headaches that are new or change in their chronic headaches, then they need to come in and be seen. Any sort of visual changes, any sort of gush or loss of fluid is concerning, they need to come in and be seen. Candidiasis or vaginal discharge in general is concerning because it increases the risk of premature rupture of membrane, preterm delivery. We're talking about what regular contractions feel like, and they'll also go through every time their follow-up visits. All right, that is it for today. Thank you.